So thank you very much. It's a delight to be here, and I am very grateful to the two excellent speakers who have gone before me, because you've really set the context. And just touching off from the previous talk on pain, in the current disability guidelines that came out in March 2024, we have included a pain score. And that pain score is in addition to the scoring that you will do to hemophilia joint assessment. And that is because we appreciate that patients who are living with chronic pain should be given additional points for their disability. Now, as doctors, you all work very hard and you treat your patients, but many times there are issues between patients and communication problems, and often you feel underappreciated. And I think one of the most important things that you can do in order to change that dynamic is to do very good medical counseling, especially for chronic diseases where we know that there's going to be a lot of problems. So just as medical counseling is important for us as doctors to make sure we have good communication and protect ourselves, genetic counseling is really, really important for the family, because it helps them make sense of what is going on, and it gives them the information and empowers them to help their future family. Problem, but I'll just give a general talk then in case the slides are not coming up. So we know that this is an X-linked recessive disorder. Now what does that mean? It means that it is only on the X chromosome, the mutation that leads to hemophilia A or hemophilia B. Now it's very, very important when you're doing counseling to not kind of make it seem as if the woman is at a fault even though she's carrying the mutation. Now, how does the woman get the mutation? If a male who has hemophilia has children, all his boys will be normal and all his daughters will be obligate carriers, right? So the woman hasn't really done anything wrong. And the reason why I'm highlighting this is because we have had meetings which were organized by the HFI, where I met hundreds of women who had children who had hemophilia, who had been abandoned by their husbands. So this is something that we need to be very, very careful about, and we're actually doing a study right now on female carriers, because they suffer a lot of guilt and trauma, and often they suffer abuse from the families as well. So as a doctor, we shouldn't make the problem worse. We should try our best to help them. Oh, thank you so much. So how is hemophilia caused? We all know it's a genetic disorder. It's due to changes in our genes, and the change in our genes is called a mutation. And the mutation will either affect the clotting factor 8 or clotting factor 9. The mutation is inherited by all the members of the family. So if you have one child who has mild hemophilia A, all of his other relatives who are also hemophilic will also have mild hemophilia A. And if you have a family where you have one person who has an inhibitor, there is a very high likelihood that other relatives of the same family, the brothers, the cousins, the uncles, may also have a chance of having an inhibitor, because they will have the same mutation, and certain mutations are at higher risk for having inhibitors. So, and a question that we are always asked is, why do men only have hemophilia? Well, in rare instances, women can also have hemophilia if there's lionization, or if they, if you have a carrier who marries a hemophilic patient. But predominantly it is because the mutation is on the X chromosome, and because women have two X chromosomes, the normal X chromosome can help protect the woman and they will develop factor, while in men, because if they have the affected X chromosome with the mutation, they only have a Y chromosome, and that is why they will have the deficiency of factor. So that's one of the reasons why it happens. But we have now come to know that women who are carriers, all of them are not normal. There are now several subtypes of carriers. Some will be normal, some may have a few problems at certain times of life, and some may actually have low factor levels and may end up having menorrhagia and other problems. So it's important to not completely ignore the carriers. They may be affected. Now, genetic counseling is really, really important because in India, most patients don't understand about genes. They think about disease as a punishment, for some bad behavior or something. So it's really important to make them understand that we have no control over our genes. We all have mutations. Certain mutations you may not even get to know. Now that we are doing a lot of NGS for things, many times we do NGS for one disease and we find that there's some mutation, but actually the patient doesn't suffer from a disease. So having a mutation only doesn't make you a patient, and many people may have mutations that they don't know about. But genetic counseling is very important for patients, not only for hemophilia but also for hemoglobinopathies, because people often don't understand that carriers can be normal, and that is why it's very important to know your family history. And again, many times people don't understand family history, so again, when you're asking family history, don't just ask about do you have hemophilia, because they may not know the name hemophilia, but they may know relatives who have joint problems or bleeding or needed transfusions or other things like that. So the more detail you'll get in, the more information you will get. Then we need to explain to them how this is carried on into the next generation and explain the treatment options and what they can do for prevention. So for inheritance, this is just a graph that shows that if you have the male who is a hemophilic patient, none of his sons will have hemophilia and all of his daughters will be carriers. Now if the woman is a carrier, which is in the second graph, half of her sons may have hemophilia and half of her sons will be normal. And amongst the daughters, 50% of them may be carriers. Now this is very important to emphasize because many times in the hemophilic community, because they have suffered, they have a kind of a bias against the female carriers. But that was, I think earlier it was a problem because we didn't have prenatal testing. But now with prenatal testing, these female carriers can go on to have normal boys and normal girls. So this is very important to reassure them because we have come across many carriers who did not get married or were stigmatized. So this should really not happen. Now occasionally we come across families where there is no family history and they have a child with hemophilia. So it's again important to emphasize that though 2/3 of families will have a family history where maternal uncles, maternal grandfather, other cousins may have hemophilia, there are about 30% odd patients where there is a new mutation. We do not know why these new mutations happen, but they do. And you may have a child who is now affected, and now in this family, they will have hemophilia and they'll behave like the families where there is already a family history. So this is a new mutation, but now they will go on to be like the family histories with the hemophilia. So again, try not to stigmatize. This is just an accident. It's a gene that gets mutated. It can happen to anyone. And a very interesting thing that has come about this is in the West, earlier they had this 2/3 with family history, 1/3 with new mutation. Now because they are very well aware of genetic information and they're doing prenatal testing, now more than 50% of the hemophilia patients that are seen in more advanced countries are actually those with new mutations. So the mutations will happen, so it is not something that we can completely eradicate. So I just want to let that know for administrators and other people, because people feel that okay, if we do tests that we can eradicate this disease, no new mutations will continue to happen. Now when we're doing genetic testing, there's several things we need to do. First of all, we need to test the hemophilia patient because that is where we identify the mutation. As I said, the mutations are many in hemophilia A, there's many mutations, hemophilia B also there's several mutations. And if you have the patient, you can do a sample and by linkage analysis you can easily and cheaply identify the mutation. Sometimes what happens is that there is only one hemophilia member in the family and that we may lose that patient. So if you don't have that patient, if that patient is not alive, and you have maybe a sister who needs to get carrier testing, then it is a little bit difficult because you can't do linkage analysis, and then you have to do the whole sequencing of the gene to identify the mutation, which is much more time consuming and much more expensive, and there are fewer centers that can do those tests. So if you have a family, particularly if there is only one family member, maybe it's a new mutation, then definitely make sure that the mutation testing is done. You don't need to do the carrier testing of the female child. Usually we recommend that you do the carrier testing when the girl is older, maybe before she's getting married, or definitely before she's planning a baby. Then the utility of having this mutation testing is that you can use it for carrier testing, and the second you can use it for prenatal diagnosis of the unborn baby. So unfortunately, prenatal testing is not available everywhere, but the government is working towards increasing this, and then there can be good referrals of these patients. We often get a patient on a Saturday afternoon who wants to get prenatal testing, who has not had a mutation test. She does not know if she's a carrier. So that is where a lot of trouble occurs. So it's always better to plan these things ahead so that we don't miss the opportunity that we have of offering the family this important information of prenatal testing. So this is basically what you do with your mutation test. We identify the change in the gene, and this is important because now when the prenatal testing is done, we can take only a small tissue of chorionic villus sample or something, and with that we can identify the mutation, because normally when we identify hemophilia, we take a blood sample, which is a large volume blood sample, and so obviously that cannot be done in the fetus. The carrier testing, again, a lot of times people say, okay, let's do the factor 8 or factor 9 levels. So as I said, there are a few carriers who may have lower factor 8 or factor 9 levels, but the majority of carriers actually do not have low levels, they can have normal levels. So factor level assay is not a good means of correctly identifying all the carriers. We should do mutation testing. So what is prenatal testing? Prenatal diagnosis is the prevention of birth of an affected child in an at-risk couple. So first we need to make sure that this is an at-risk couple. Simply being a sister of a hemophilia patient does not make you a carrier. Many sisters may be normal and not carriers. If you are not a carrier, we do not recommend any kind of prenatal testing. Nothing is required. If the sister is a carrier, when she gets married, then prenatal testing should be offered to her. This is the way that it is done. There are many ways that you can do it. You can do it by chorionic villus sampling, amniotic fluid, chordocentesis can even be done, and there are now some newer tests where they are able to do it by the blood, but at the moment those are not available for us in India. So it is the mainstay of a prevention program. But the most important thing is that the family should request this. This should not be something that should be enforced, and if the family requests it, then there are many other conditions for which prenatal testing can be done. In hemophilia, a lot of questions come up that is it allowed by law, because we already have a law on predetermination of sex. So if you can reassure the family, the report is given as affected or unaffected. So if the report is affected, it means the child is a male who has hemophilia. If the report is unaffected, it could be a male who is unaffected, it could be a female who is a carrier or normal. So this is how the report is given, and this is completely allowed by law. No sex information should be given, only the information about having the mutation or not having the mutation. But you need to make sure that you have the adequate sample, and you have to, and in order to get the adequate sample, first you should have counsel the family, because what are they going to do with the test? That needs to be explained to them, what their options are. Also, every intervention has some risk. There are some patients who might have a miscarriage, or they might have bleeding, or they might have other problems. So the risks of the procedure has to be informed. The type of procedure that is done depends on the gestation age. So you can do CVS sampling at 10 to 12 weeks. If the pregnancy is beyond that, then you can't do chorionic villus sampling. It is not allowed. You then have to go to amniocentesis. Amniocentesis has certain fallacies, but it can be done later in the pregnancy. And if the pregnancy is again further advanced, you have to do cordocentesis, which actually means taking some blood from the umbilical cord. That again has certain risks and fallacies. So on the whole, usually we recommend chorionic villus sampling, which is done early on in pregnancy. It is the safest, it is the most informative, but again, nothing is 100%. If there is maternal contamination, you may get a false negative report. So that also has to be explained to the family. So the timing and the risks are very important to counsel, and it's important that they understand that. And this is why it's always a good idea to discuss this before pregnancy, because now if you already have pregnancy, the clock is ticking, there are other stresses, maybe the mother's not feeling well. And again, many times it's important to discuss this with the whole family, because often it is not the woman who is making the decisions, it may be in-laws or parents or other people. So where can the prenatal testing be done? Any center that has a good, competent molecular lab and a skilled gynecologist who can take fetal samples, they can do that. Genetic counseling facilities should be developed in these centers, and if the family chooses to go for termination, then a good obstetrician and excellent obstetric care should be offered to the family, and again counseling post these procedures. So there were a lot of misconceptions about carriers, as I said, and it's very important that any kind of coercion should be avoided in doing prenatal testing. Though the government has now made packages in Ayushman Bharat for prenatal testing for hemophilia, thalassemia, and sickle cell. So for patients who are unaffording, this can be done. So it's important that this is we have a good discussion with the family so that they can clear their doubts, and we can counsel them in case that they are needed, right? And there should not be any stigma of carriers, and that is something as a physician community we should take every opportunity to make sure that we don't add to their trauma, and often it can be useful if we discuss separately with the woman, maybe not with all the male members of the family, and we can then guide them on what they can do to further protect their family and avoid having further children with that. So counseling, as I said, is so important. The genetic counseling identifies the mutation in the family and can give them the empowered information for prenatal testing and carrier testing. We must make sure that other women in the family are also tested and informed, because often there's a cousin or somebody else who may also be at risk. The carrier counseling should be done to ensure that these women are told that they are normal, there's nothing wrong with them, and they can have normal children in case they follow the advice and go for prenatal testing. Treatment counseling is very important for the family of affected children. It explains the long-term treatment, educates the community, and ensures the safety of this. So there are a lot of ethical issues when it comes to genetic testing, genetic counseling, and it's important for all of us to be aware and to follow these principles. Yes, there are definitely advantages to having prenatal testing and genetic testing, but at the same time we must make sure that we protect the rights of the individual and the family. And as I said, no genetic test is 100%. We have had families who've gone for prenatal testing at Aiims. For example, for thalassemia, they were told the child is not affected, and then when the child was born, the child was affected. So there is always a slight risk on that, and so again, if you've counseled the family beforehand, it makes it much easier in case there is such a fault. And though we do want to prevent the births of these children, in the West they actually don't, because they have access to treatment and they have much more funds. In India, of course, we have to take a very balanced view, and we need to kind of look at this. There's an article on genetic testing and prenatal testing where they say it's an easy test, but it's a hard decision. And that's where, as the doctors, you are here, you can counsel and you can help the family during this stressful time. So just to remember the steps for prenatal testing, first you need to have genetic counseling so that they understand their options. We find out the mutation, we do the carrier testing, and then at 10 to 12 weeks we do the CBS testing and make sure that post-testing counseling is done. So with all of these tests, we can make sure that the family can have a healthy future family, and they are protected and empowered. So awareness is very important. Knowledge is definitely power in today's age, and we need to have many more good prenatal testing centers available in our country. The access part is somewhat being taken care of by the government, by the Ayushman Bharat packages, but good treatments, if they come, perhaps we will not need to do these kind of things. The family, if it's informed, it can make good informed decisions for their future health, and there should really be no pressure from any of us to go for termination. The termination decision is the family. We have had some thalassemia families where they were told that they would have a thalassemia major child, and because of religious reasons they decided not to go for abortion, but they were prepared for the child. So again, as doctors, we can only help the family, we can inform the family, we can guide the family, but the final decision has to be theirs. So thank you so much. Any questions?
Ma'am, this is kind of a difficult question, so which I very frequently wonder. So if the affected fetus is a female carrier,
the affected fetus, the affected will tell you only if it's a male with hemophilia. The sensitivity is not such that you can tell it's a carrier. So the carrier will come in the unaffected. So that is where again the problem is, because the families often say they want to know if it is a carrier, but technically who are there have to be identified as carriers or non-carriers. And that identification, we usually don't recommend that they do it when they're little girls, because sometimes they can be bias against the carrier child versus the non-carrier sister. So we recommend that they do it close to either marriage, either pre-marriage, or at least definitely before they have a planned conception, so that we identify these carriers. Because as I said, that is the cornerstone of a prevention program, is to identify the